All right, welcome everybody. This is our fourth week of the supporting parents with children with challenging behaviors. We're doing this through Community Mental Health for Central Michigan. My name's Mary Schreier. I am the Autism Supervisor for CMH and a board certified behavior analyst. And we have several people from our team helping out, other behavior analysts. So I think today we're gonna have Jason Otto, whose office is more in the Claire Gladwin area, and Jennifer Woods, who works for us part-time as a behavior analyst and also works for the schools in Midland, supporting kids with behaviors. So we have her helping us out. And then Courtney Stegman, behavior analyst based in Midland, but also hit some of our other counties. We also are in the Mecosta County and Osceola, and I think that covers all of them. So Gladwin, Isabella, Claire, and Midland. And then Jen from Autism Alliance of Michigan, is it Jen Jaeger?
Jaeger, yep.
Jaeger, okay. So she has kindly agreed to join us too to help with some, give some other resources throughout the state if there might be questions. So throughout this series, we've tried to keep it a little more broad than just focus on autism, even though that is our team's focus at CMH. We've tried to make it a little more about challenging behaviors that could be any children and, you know, even our spouses, to be honest. But, so we've tried to keep it a little more broad. Today, I think we're going to be narrowing in, talking more about specifically if they are or might be diagnosed with autism, but also keep in mind it could be just other special needs that they might have as well. And if you've got other questions, you know, that are not autism, that's fine. You can send us a message through the chat, or you can send us an email, and we will definitely have time at the end for questions where you can just unmute yourself and join us as well. I think that's it. So we will go ahead and get started, and I'll let you guys tell me when to move the slides forward.
You can go ahead and move it forward.
Okay. There. Did it go too far? It did, didn't it?
Yeah, you need to hit pause. I don't know what that is. There you go. Nope, you're good, you're good, you're good.
Okay.
Okay. So I'm going to start off talking a little bit about some different aspects, and then we'll go in a little bit deeper later of all of them. So ABA is Applied Behavior Analysis. Sorry, I didn't write that in there. And that's what we practice. And like Mary said, we generally only work with individuals who have autism at the CMH level. So ABA is the use of scientific principles of learning and motivation to teach effective skills. And the core concept of ABA is that the consequences of what we do affects what will happen in the future, whether or not we'll engage in that same type of behavior or not. And it's important to remember that with ABA, reinforcement is key. And that being said, reinforcement looks different for everybody. In the first week, I talked a little bit about how people don't do things for free. So that's something, it's extremely important to remember, because motivation drives us to do anything. So some examples of that would be going to work to get a paycheck, helping somebody and feeling good afterwards. If you didn't feel good about doing that, you might not do it the next time you have that opportunity. Getting approval from others and reading a book and getting satisfaction from it are all some examples. Go ahead, Mary.
Oops. I think I did it wrong again.
Yep.
Is that the right one? Nope,
Nope.
next one. Okay.
So early on, ABA kind of focused on discrete trial training, which is your old-fashioned sitting at a table with some cards and really doing intensive programming with kids. Now we utilize a more comprehensive type of programming which includes several different types of behavioral teaching strategies. like discrete trial training, because there are some kids that still benefit from that. I would say that the majority of all of us right now are probably using more natural environment training or teaching, that's NET. And I would probably be willing to bet that you all are using a lot of NET right now, that we're all in this quarantine. In addition to those types of trainings, we target verbal behavior, challenging behaviors. We utilize data collection to really make sure we're utilizing the right types of interventions. In addition, we also program for generalization and maintenance, so kids can keep those skills that they learn. So there's a wide variety of treatments and therapies. And when we're talking about autism specifically, there's 3 main areas that are impacted, being social interactions, verbal or nonverbal communication, and restricted and repetitive types of behavior. Go ahead, Mary. So looking at those 3 things, there's already a huge difference in those areas. So we can touch on the therapies that there might be for speech. So we work on the communication piece. The behavior piece might be more ABA and or OT or PT to work on some of those other types of things. And so additionally, there's cognitive differences that come too. Difficulty shifting attention, processing 2 cognitive tasks simultaneously, problem solving skills, having a difficulty with sense of time, things like that all come into play and need to be addressed. So attention is also a huge one. Studies have suggested that at least 75% of children who have ASD have a profile that's indicative of ADHD. And I did not double check this, but I'm curious. I don't know, Jen, if you know if there's any update to this statistic or not. Jen Woods.
Yeah, I haven't looked into that, but that's an interesting question. Maybe while we're presenting, I'll take a peek and see if I can grab something.
Yeah, as I was reading that was curious.
Absolutely.
So, but that being said, attention also looks differently. So that's not going to be treated necessarily the same way either. Having a difficult time to sustain attention or to utilize attention as it pertains to relative information. Shifting attention can also be a difficult thing, and then memory, all things that we can build on with ABA principles.
Okay, I'm going to join in and talk about evidence-based practice, conscientious use of current best practice evidence to make decisions about student interventions is sort of the mindset in a couple of different big projects of reviewing research, and a couple of publications list and itemize all kinds of interventions that are deemed best practice. They're based on systematic search for an appraisal of the most relevant evidence to answer these questions. Also, one's clinical experience and expertise are weighed in, and also data based on guidance. And next. So there were a couple of big projects. If you're curious about these publications and haven't heard of them or can't find them, please reach out to us, Mary, and we'll get you those links. So on the left column, you can see these are the evidence-based practices identified by the NCAEP. And the grid shows along the top the National Standards Project review of similar titled interventions. And Courtney hit on a few of these. We've talked about antecedent-based interventions in this series. And in one standard that's collapsed all these checks into behavioral interventions in general. By the way, I'm presenting this in a point that these are behavioral interventions. They happen to be focused on the population of autism. But it doesn't mean that all sorts of disciplines, speech pathologists, occupational therapists, even knowledgeable physical therapists may be using any of these interventions in spite of their being ABA wheelhouse. One unique one, cognitive behavioral therapy, that's quite unique. Most behavior analysts wouldn't consider themselves experts in that. It's actually a therapy outside, but that's deemed evidence-based. These others are familiar terms: differential reinforcement, discrete trial training, extinction, modeling, naturalistic interventions, which is basically doing what the kid enjoys, teach them to ask for a toy while playing, teach them to ask for food during a meal. Parent implemented interventions, that's therapists teaching the parent to carry out protocols. Peer-based, for example, teaching a peer to respond quickly and with reinforcing response to a child who initiates an interaction, for example. Prompting, real common, evidence-based reinforcement. Response for interruption and redirection, effective for, say, vocal stereotypies, interrupting it and prompting them to say something else. Self-management, social narratives, social stories has been moving up a little bit in some of the standards criteria. Social skills training, task analysis, and so on. Okay, we can move on. So both of these reports are really long, and I recommend you look into them when you're looking at interventions you're doing across these disciplines. And you can proceed to the next flowchart. So sometimes we'll be in meetings where people will propose some intervention. Most people may not be looking at those standards of evidence-based practice, but even if they are, Matthew Broadhead at Michigan State made a nice decision flowchart that is good to kind of assess some basics. Is the intervention being proposed risky? If it is, well, you better speak up. If it's not so risky and you aren't familiar with it, do your homework. Is treatment success possible if we try to understand it and apply it to behavioral principles? If so, then go ahead and go forward. There is another thing called the capped, and we can proceed to the next thing. You get to a point where it seems like it might be plausible, then there's a further evaluation. You can look at areas such as, is it function-based? Is it involving acquiring a specific skill? Will it promote important social outcomes? Will we be collecting data on it to evaluate it? Can we implement it in any formalized way? If no one can really put your finger on what the intervention is, you're not going to have treatment integrity, meaning we're not going to have a formal action. Social validity, do we like it? Does the client like it? That might sway a decision. And finally, is it really expensive? Is it going to be cheap? Maybe it won't be so costly in terms of time and effort. Okay, next. I'm going to look at sort of medical interventions and what we think about in terms of collaboration with medical things in mind. The differences in how autism spectrum disorder affects each person means that people with autism have unique strengths and challenges in social communication, behavior, and cognitive ability. Therefore, treatment plans are usually it's easy for you to say, multidisciplinary, may involve parent-mediated interventions and target the child's individual needs. Established interventions, like I just hit on, are the first choice, while medical oversight and rule out is important for challenges. And next. And I'm speaking, of course, to challenges in general, but also behavior challenges. We always want to rule out medical reasons before we spend a lot of time and effort. And a behavioral intervention, whatever discipline is doing it. Some things that you may have heard of, basically otitis media is an earache. It's not uncommon to hear sounds can be aversive for some children. Well, there might be an ear infection. It's a well understood cause for some self-injury when it's present. And getting hearing and vision checked, reading on vision therapy doesn't seem to be supported, but that's a thing out there that you might be wary of. Sleep deprivation disturbances is a problem in its own right, but then it leads to problem behavior as well. Allergies, food allergies can lead to problems. In the unique cases in autism where females, dysmenorrhea is painful, leads to problem behaviors. And I'm sure everyone who's been in this field knows the number of gastrointestinal disorders, from constipation to diarrhea, might lead a team to do a good job of monitoring that. And next. Going on with heartburn, GERD, a common thing that can lead to things specifically such as feeding problems could be related to that. Seizure disorder, it probably wouldn't be missed, but that's noted. Genetic disorders. On a different conference call, Dr. Megan, chair of the psychiatry at MSU, recommends, of course, a multidisciplinary evaluation, but even so far as getting genetic testing for children across the board. He said it might not lead to anything helpful at the moment, but it could give you information that is helpful. Motor deficits, bring in physical therapy. Generally, oral health problems can lead to problems. Okay, next. Drilling into more discipline-specific skills, speech pathologists can really help with feeding disorders, dysphagia. Sometimes feeding issues are really about a swallowing difficulty, and behavior analysts really should be wary or cautious in making sure that there aren't issues like that, because there's risks of aspiration, choking, and so on. For example, a doctor might order a barium swallow test to determine that, and lead to thickening of liquids and specific textures. In the discipline of speech pathology, they do have a specialized certification for swallowing and those disorders. Also, occupational therapy also gets into this, and they have their own specialized certification as well. Okay. Now, aside from swallowing, speech pathologists can have real specialized knowledge in motor movement in speech disorders, such as the boy, I put stuff in I can't read, phonological disorder and apraxia of speech. They have certain tests, such as the Kaufman speech praxis test, which can kind of suss out, although it is difficult with children who may be nonverbal already with autism, but they can suss out the specific style of errors, such as an echoic, where the errors are inconsistent. They could add some insight. Speech pathologists have also provided thoughtful prompting techniques, such as phonetic hand cues, while we may be teaching echoic, such as, say, ha, ah, they might train a hand cue to pair with that. They've also, Kaufman has, we're zipping it, Kaufman cards, they really understand the phonetics and the motor movements of producing sounds, and an average behavior analyst may not know the more difficult sounds, but we've got a head up because one of our assessment tools was designed by a speech pathologist to help us rate and have the easier ones assessed first. And that was my part.
Okay, so we've talked about, again, everything that can kind of layer in with a behavioral need or autism spectrum disorder specifically, and gone over ABA and then evidence-based practices, as well as the medical layer. And now, of course, in there is this layer of school and the educational arena. So some of this you'll see reoccur. You'll see, you know, the medical side of the speech therapist, occupational therapist, but then it shows back up, as well as ABA. So on this slide, it talks about the applied behavioral analysis again. And as a reminder, what are we doing? We're working to change behavior in a way that allows for some pro-social, increased independence, plus always trying to teach new skills. The speech therapist is also on this slide, and again, from an educational standpoint in the school system, focusing on communication, overall use of language, socializing with peers, and gets in depth in certain situations, kind of what Jason was speaking about as well. You'll see that in some other slides. Okay, Mary. Sorry guys, I can't turn my message dinger off, so that's what you're hearing. So examples of the speech therapist in the school system, again, not always different, but then sometimes different from how is this impacting your educational day? How is it impacting your socialization during the school day versus the medical model, which may, in certain situations, get into that feeding, swallowing, more specific medical lane. I think what's interesting on this slide, if you'll pay attention to bullet point 3 or 4, matching emotions, understanding body language, also something such as introduction to speech apps, compatibility with technology, looking at using iPads, different options and opportunities for communication to make, again, the target student independent. And then even focusing on tone of voice. Tone of voice helps with socialization and communication. If someone's too loud or too quiet, it helps me to want to interact with them or not interact with them from a behavioral standpoint. Okay. So this is just a blurb from one of the speech pathologists that does work in the school system when we were allowed in school buildings at one time. And she also used behavioral strategies. So what she's speaking to here is that she used the token economy, and they also had in their building a jar that you could accumulate things in. And so then during the speech session, that collaboration across the day of supporting behaviors, supporting learning new skills, and there's that ABA layer in there as well. Also, like Jason spoke of earlier, the evidence-based practices that she's using off that list are likely infiltrated in here to get some of that communication happening. Okay. Occupational therapists also and physical therapists are in the educational arena. The occupational therapists at one time focused a lot on sensory integration. We've evolved from that, and the occupational therapists do still work on our sensory needs, but in a pretty functional way. And so there are times when access to a ball pit or a swing or a trampoline is wonderful and help you kind of regulate your sensory system, but we also know that they're not available all over the place and can impede independence as well as socialization. So fidgets and different, self-regulation strategies, which you'll see in a later slide, is somehow what you'll see an occupational therapy individual in a school system integrating. Obviously, also still fine motor, and they work on what is the kiddo's occupation. So are they a student? Are they a friend? Do they go to certain things throughout the day or after school? Are they a sibling? So their occupation is what an occupational therapist works on. And then the physical therapist works to improve core, body strength, coordination, the ability to work with both sides of the body. And again, you'll see some overlap between an OT and a PT. All of these things kind of keeping in mind behaviorally can be how a kiddo is impacted if they have needs in these areas and are needing some help from any of these individuals. I think I touched a lot on this OT slide, so you can skip this, Mary. And this is you again, Jason.
Oops, one slide back, please. So here we have a commentary from Heather, who's an occupational therapist, and continuing on what Jen was talking about in terms of sensory issues, and that being OTs, oftentimes their understanding. Self-regulation. It's a person's ability to respond to a situation while keeping their body and emotions in control. At school, they might use something akin to the zones of regulation, which helps them sort of rate using a color coding system, the situation and the response, which might serve as a good prompting strategy and script, which are both evidence-based. And, you know, as long as you can stick to the prompting and scripting strategies, then using that could be quite helpful for the child to understand how they're feeling and what they ought to do in that situation, such as going to a safe spot and learning the skill to cool down and relax, using aids such as lap rests or stress balls, and actions like deep breathing that might be incompatible with an overly excited response. And that's at school. At home, similar things, using language to size up the problem as it deserves, using demonstrations, which is an evidence-based practice of modeling, showing the child to deep breathe, showing them to walk away to a safe spot. In crisis intervention, you often learn that just changing the location and leaving a scene of whatever it was that caused a problem can help de-escalate. And of course, recognize and reinforce the child's responses of self-regulation. Okay, we can go to next. So social workers, case managers are take on many roles and really important. They can be wearing many hats, such as a clinician, a consultant, an educator, and an advocate. Because of these various roles, it's important that the school social workers be knowledgeable about all facets of autism, as well as other diagnoses and the processes and assessment, and the range of evidence-based intervention efforts. Case manager or service coordinator can help with questions, problems, or concerns that arise. Case manager keeps current records and, when appropriate, shares information about a child with professionals involved in that child's care. It's one very effective way to make sure a child's needs are being met. Case managers may also help by making sure all appointments are scheduled, tests are performed, evaluations are conducted, and that appropriate and effective follow-up care is being provided. So other things just to think about is, where are the services being provided? ABA, speech, occupational, physical therapies could be done in the private clinic setting, at school, through an IEP, at home, as part of an early intervention or homework from those therapists. In the community, practice new skills in the natural environment, and services can be provided one-on-one or in a group setting, depending on what skill is being practiced. And I think now we can open to questions.
Kathy, I'm wondering if you would want to tell us a little bit about what you do in your role at CMH.
I'm assuming I'm the only Kathy here.
Yes.
Trying to scan. Sometimes in the room at my age, there's like a million Kathys. So my name is Kathy Schaefer. I'm a parent support partner for Isabella County. The parent support partner's role is to do what it says, which is support the parent, but in a way that walks alongside the parent with their wishes, needs, culture, help them navigate systems, understand what they're doing, and really dig into what it is they want for their child. Whether it's a parent or a caregiver, both can go. It's a service in the state of Michigan for a children's case, and that has to be under the age of 18. What else can I tell you about it? Oh, I have my job because I'm a parent of a child with a disability, and that's the only way you can become a parent support partner. So my child now is 23, has autism. Not all parent support partners have children with autism, but I've navigated many systems on my own, figured it out, and now it's my job to support others by sharing my story and not keeping it to myself. So a lot of times the boundaries between a parent support partner and a normal working clinician or person, they're there. But my job is to share part of my family life to the extent people ask me. So they might, I often get my brain picked, well, how did you know your child was ever going to go to work? And that's a fair question. And how did you work with your husband on co-parenting when you didn't agree? Fair question. So a lot of those questions could get answered. And just talked about brainstorm, give parents a voice and choice is a primary goal.
Cool, thank you. Jen Yeager, will you tell us a little about what you do with Autism Alliance as a navigator?
Yeah, sorry about the lighting and everything.
All right.
Work from home life. So as a navigator at the Alliance, we kind of deal with any and everything. One of the best parts of it is that it's a free service. So I really do love that. Any family, individual themselves, we sometimes have support coordinators, we have social workers, even providers themselves contact us. So kind of whenever they contact us, we get a little bit of information about what they're looking for. So we have, Joanna's actually on right now. She's our community specialist. We have insurance specialists. We have some clinical specialists. And so they come to us with questions, looking for resources. We can have somebody call us in the middle of a crisis. They might be at the hospital. There's a wide spectrum of what they call us for. And we try to help them right then and there if we can. And if we can't, then we get back with them later. And so the cool thing about being a navigator, I actually really like this from being in the ABA world before, is that they get us essentially for life. So like whenever they're going through and going to new people to contact, they don't have to explain their story to us. So if you call and you get me, then anytime over the next 10 years, if I'm still at the company, they call, they get me again. So that's what I really do like. Even if we haven't talked to them in 2 years and they call back, they still have me. So as a family, that's really personal, and I do like that because, and it's also good for us as case managers because then we already know the situation and we don't have to go back through and be like, okay, explain me your story again. So I think it's a really great program. I think that, again, coming from the ABA world, I don't think a lot of families actually know about us and what we do. And that's something that I've noticed because myself, again, coming from that world, didn't really know that the Alliance had a navigator system. So I encourage so many families to reach out to us because, it could be a question about guardianship, anything in the world. And it's great because we do have resources to always, assist to the best of our ability. And if Joanna wants to say anything more about like what she does, I'd advise her to also.
How did I know you were going to say that? Hi. I'm Joanna Lofton, and my role there is I am the community resource specialist. So what I do primarily is support the navigators. I am constantly out there looking for information for families, things that we can utilize, that the navigators can utilize when they're talking to families. My primary focus is around Social Security, housing, transportation, some of the legal issues. That's the main things that I do, but I look up information on any and everything because you never know what you're going to get. Some workshops and trainings, helping families learn how to advocate for themselves, and not just families who have a child on the spectrum, but anyone with a disability. I also do trainings to help with other agencies. In fact, my own plug, I have an independent living training that is tomorrow, Wednesday, from 2 to 4 on Zoom. If you're interested or you have families that are interested, then go on our website and register. It's entitled Independent Living, a Caregiver's Guide.
Good.
Where what I talk about is what you need to be doing at the different stages of life to prepare your child for independence, and what you need to do as the caregiver to take care of yourself. So I do a lot of those kinds of things. Yeah, the Alliance is a place that most people don't know about. I think we're a really valuable gem. Our services are free, for one, and it's a bunch of really dedicated people that care about what they do.
Yeah. Great, thank you. I'm so glad both of you joined us today. A couple things that I think are really cool about the Alliance, besides the fact that it covers the state, so it doesn't matter where you are in Michigan, you can, contact the Alliance and get some information and resources about it. But also, you guys cover all ages too, right? So I know you've got support for adults, which is too often lacking with autism in particular. So, and then also, like you said, we'll touch on other disabilities too. Even though it's Autism Alliance, you're open to helping with others. So
that's a big thing too that, whenever I started there that I was told is like, you never turn anyone down, right? So we've had people contact from other states, and to the best of our ability, we'll look and try and find resources, right? We're not going to turn people away, or we've had people contact us who don't have somebody with autism. So we do our best to help whoever it is that contacts us, give them resources to the best of our ability.
Very cool.
We've even had individuals contact us from other countries.
Wow.
From where we will do our best to help. And I think it's beneficial that many of us, like you said earlier, have a child who has some disabilities. I have a young adult who is on the spectrum. So we kind of understand, and we really love what we do. I'm sitting in today really to learn more about what you guys do and your perspective. So I've actually learned quite a bit. I appreciate it.
Good, thank you. I want to open it up. Does anyone else have any comments about, any questions or comments about what you do? Let's see, it looks like we had something on chat. I want to check that real quick too. Okay, yeah, Jen Woods did say that the rate, what was it? I'm gonna let you say it, Jen.
I just looked back up what the occurrence was for attention or ADHD like characteristics with autism spectrum disorder, and it's still reporting between 70 and 80%. So that doesn't necessarily mean that that is a medication requirement. It's just they're flagging high on attention issues, could be a variety of other reasons.
Mm-hmm. Okay.
So 70 to 80%, it's still a comorbidity.
Yeah, cool. Now let's see. Jill, I don't see you there, but I think, Jill, do you do outpatient or speech? Maybe she doesn't even hear us. Megan, Prissa, either of you, and Annette, I know you're a teacher, right? Preschool teacher? Oops, yeah. Oh, here. I'm unmuting people.
Okay, yes, I'm a preschool teacher.
Okay.
And I noticed that some of the breakdown, they talked about the school and IEPs, and then under age 3 at home. But then there's that preschool age, the 3, 4, 5-year-olds or young 5-year-olds. And that's a really hard thing. I mean, we have lots of bags of tricks, but it's hard for us to get the resources that we need. I know Jennifer Woods has been in my class before.
Yeah, that you're absolutely right. It's kind of a little bit of a black hole where, and I think it's everyone's kind of crossing their fingers and hoping like it's preschool, things will get better, things will turn around, and preschool teachers or parents or everyone at that point are saying yes, but we could also be using some supports during this time, because early intervention doesn't stop then, but kind of. And that, I mean, I agree. I feel like it's kind of like, well, we're hopeful that preschool will fix you and you'll be all ready to go by kindergarten. And right, everyone's saying, and they're still little and still developing. And I feel like we spend lots of time saying, is this normal for a 3-year-old, 4-year-old, or is this something different too? So yeah, absolutely. Even my services through the school system, I sometimes will get blocked at that preschool level. So you're absolutely right. It happens again at the later post-secondary, where it's a little bit of like services start to dwindle, and everyone's still needing everything that they've needed. It's just a shift in where the need is at. So absolutely.
But I also look at some of the things we do, the social stories,
Yeah.
contracts with children, approximating behaviors, looking at antecedents. There's so many things that we have to do in preschool to have our sanity and to help the child or help the family. And that's the biggest thing. Is if a couple of years ago I had a family and they went, what do you mean this isn't normal behavior? I just thought he's a boy. And yeah, but still it was kind of off the charts.
Yeah, you're right. That's kind of where it kind of overflows at that point, where it's a matter of, all right, we're going to have to start talking about this a little bit more specifically, for sure.
And he did not receive services until first grade. And he got what he got from me, but he's doing good now, but.
And yeah, and you do a good job. So.
Thank you, my dear.
For me, I work, has she unmuted me? Yeah.
Yep, I unmuted. I think I unmuted everyone now, so you can talk.
I work primarily with evaluations of students suspected with that disorder and other disorders. And sometimes what we see with the younger ones, preschoolers, we want to be careful before we decide that a child has, is autistic, that the child is on the spectrum at all. So we want to make sure, because we know that there are comorbidities, as I think it was Jason rightly said, and all of you know that. Sometimes what's the distinction between that and ADHD? I was, the statistics of the 75%, those with attention difficulties sometimes really ASD. We've seen different things. One of the things that I've seen is 14% of children with ADHD have autism as well. And that is still, it's not as high as the 75%. And I think what you're looking at is the spectrum of Asperger's. But for those reasons, when it's not really black and white, it's not clear cut, we really want to make sure that there's not something else going on before we tell a parent that a child really has autism. And also what we've seen in the school is that the child sometimes is not necessarily used to structure at home. Nothing to blame a parent or to negate the fact that at home, yes, you run around and so forth, but they're just acclimatizing themselves to the school structure when they get there, and sometimes still in the stage of I'll do it my way, and display those disciplining problems, and sometimes it's suspected that there's an issue, but maybe not. So as far as we are in the school system, we really try to use the social stories and other forms. We used to do a lot of discrete trial interventions, just teach a discrete skill. And, I know that's old time a bit, but there are other ways of intervening, be supportive of parents as best as we can. So That's pretty much. Of course, there is so much more to it, but that's as much as I'll share this afternoon. Really, you know, we enjoy them as they come, and we just our focus is not to say that the child has a disability at the first instant of behavioral issues. Thanks for everything that has been shared this afternoon. By the way, you guys are a great team, really.
Thanks.
Thank you.
You're welcome.
Yeah. Anyone else? Megan or Tiffany?
So I'm the youth intervention specialist for Isabella County. We have youth intervention specialists for all of our counties that we serve, but I do the Isabella County. And we work with the schools. The schools typically give us the cassette forms, and we screen students for mental health services. The schools are usually the ones that identify the students that might benefit from being screened in mental health services. Then we go to the school typically and evaluate students for mental health. We'll do a screening with the child, usually for about 45 minutes at the school, and then we'll, if able, gather information from the school as well as talk to the parent guardian and gather information, and then we help parents link up to services in the community. It's a free service. They don't have to have Medicaid, but we do link to services depending on what insurance that child has. We also go to the schools sometimes if we're available for crisis situations and do safety planning if needed, and those kinds of things.
Thank you. Tiffany, you have anything to share today? Or any questions for us?
Nope, you guys did a great job today.
Well, thank you. I know you've been navigating this too, so. You wanted what?
I just wanted to get a copy of the slides.
Absolutely. Yep, I will send that out.
A copy of the slides again.
Yeah. Okay. Yeah, I'll make sure I've got your email. I'm not sure if I do. I know I do somewhere, but just I can send you the slides for all of the weeks. If any of you want them, go ahead and email me to mschreier, SCHRIER, at cmhcm.org, and I will send those. I know I've got most of you on email, but if you haven't received an email from me yet, then send me one and I can get you that. So, and then I will also get you the link for the recordings from all 4 weeks. So, we are looking at starting on, what's that?
I just said thank you.
You're welcome, Tiffany. We're looking at starting another series, a second series in June, probably the first Tuesday in June also, and kind of going up maybe a little more in depth. We might look at like things we can do while the kids are, while families are waiting to get services started or to get tested for ABA. If there's other specific things that any of you want information on or think would be useful, please go ahead and send me that as well too. Anything else from anyone today? I think the one other question that came up in my mind when I was listening to all of you was, I can't remember, oh, Jennifer Woods, when you were answering Annette about the preschool, and you mentioned that similar things when they get older too. And I think like Kathy and Joanna, it sounds like you both have dealt with some of that transition period of transitioning into adulthood. Do you have any comments on that? I know Joanna, sounds like you've got a whole couple hours planned to talk about that tomorrow.
I do. I think the biggest thing that, especially those that are working with our young kids in the school, is helping the parents realize that it starts then, looking at someday they're going to be an adult. And I don't usually say it a lot, but the idea that you're going to be dead and gone, yeah. So you have to start when they're little, preparing them for being an adult someday. And there's so many tools out there that parents can use now, but if you can just instilling them that yes, this person is going to be an adult, have the same wants, needs, and desires as our neurotypical kids. Because oftentimes they don't think about that. You know, they don't think about the fact that they're going to grow up someday. They could get married, they could have children. They're going to have the same wants and needs. We might have to acquire them differently, but it's going to be the same thing. And I think we forget that. I know I did for a long time with my own kid.
Yeah, for sure. Yep.
I think if I can echo that, it's one of our goals at schools. So it's really getting the student independent as much as possible. It's an awareness that we try to really promote, not only to parents, but to the educational community as well.
Yeah.
That the child, regardless of their impairment or disabilities, we just want them to be as independent, and then that builds a sense of, you know, of control really to themselves, that I'm capable, I'm able to do that at some level. And I know it's hard sometimes to instill, but it's a goal anyway. And by the way, the data that I told you about, the 14% of children with autism also have ADHD, is from the CDC data.
Okay, good.
For disease control. Mm-hmm.
Yeah. I want to add to what you both said too. I think even with our team, our program, with working with kids with autism and specifically providing ABA, the program ends at age 21, but even from the time they're little, one of our big goals is to make it so they don't need us anymore, you know, to give them those tools, because we want them to be independent. And we encourage the families to look at how can we make them so that they can be independent, you know, at 10, and then obviously older, you know, the older they get, the more independent we want them to be. And I think, you know, this kind of goes back to some of the other weeks we've had of, you have those little goals and accomplishing those and celebrating those. And I think it's the same type of thing too. You know, we as parents feel more successful when we see our kids having that success too. So it all just builds together.
Mm-hmm.
Yeah, true. It's about having expectations for them other than keeping them safe. And that's oftentimes the biggest thing as a parent we worry about, is keeping our child safe. But one of the ways to keep them safe is have expectations so they can be independent.
Yes, absolutely. Yeah.
Mary, I put in that chat, I don't know if you, I mean, I know you have my information, but if you'd like to pass it along to any families, or if anyone here would like my information, I'd love to give it. Or, I mean, I can pass along the whole Navigators in general, but I don't know if people contact me directly.
Good, perfect. I will send that along then too.
Okay.
Yeah. All right. Well, I think this has been really great, and hope that you've gotten good feedback out of it, good, useful information. And I hope I will see some of you again when we start round 2.
Great. Thank you so much.
Really yeah, take care. Enjoy the next couple of weeks.
Thank you.
Bye-bye.
Bye.
Bye.
Bye.